the group. Just want to make sure that you do see the main screen. Can you see the main screen, Mika?
Yeah.
Okay,
Looks good.
perfect. Okay.
Oops. Hi, Jill. Thanks for calling in.
Okay, so what we will try to accomplish during this session is to identify unique differences in a pediatric physical assessment, utilize pediatric systematic approach for pediatric physical assessment, utilize primary assessment for assessing the pediatric patient, also to go over red flags in a pediatric assessment and pediatric conditions, and also to go over some of the most common pediatric respiratory conditions and as well as the circulatory conditions. So just to start the session, just to give you sort of a little bit of a background, what makes pediatric patients so much different compared to adult in terms of their assessment? So history, right? So you rely on parents and caregivers to collect the history. Also, relationship with the family is extremely important because that's sort of in the foundation how the care will be delivered. Cooperation during the exam could be quite challenging because you have to know developmental stages of the child in order to be able to conduct the physical exam effectively and gain cooperation of the child. The same goes for explanation of the procedure. Depending where they are developmentally, the explanation of the procedure varies. What you're going to explain to a school-age child is very different how you are going to talk to teenagers. And also there are significant anatomical and mental maturity changes that you need to be aware of. And of course, medications, as you're aware, you know, whenever we administer medications to pediatric population, it is all based on weight. So therefore, accurate weight is extremely important in terms of pediatric medications. So the next slide sort of summarizes the key differences of pediatric anatomy and physiology, which, you know, explains why kids are sort of susceptible to certain conditions, why they're unable to compensate to the same extent that adults able to, and also why, you know, they would be, you know, predisposed to certain conditions. So first of all, kids have a large body surface area compared to their weight, and that in itself makes them very predisposed to hypothermia, especially like a small infant. For those of you that do have some experience in pediatrics, perhaps you've noticed that small infants are extremely sensitive to thermoregulation, and therefore they can get cold really fast. Also, anterior fontanelle and open sutures palpable up to 18 months of age, and posterior fontanelles closes between 2 to 3 months of age. So that in itself can make small infants predisposed to losing a lot of heat through their fontanelles. At the same time, that could be also a marker if they have something pathological going on. For example, if they're dehydrated, they'll have sunken fontanelles. If they have some issues with increased intracranial pressure, they'll have bulging fontanelles. They have a large tongue compared to the rest of the body of their oral cavity. And As a result, so there is not much space left in the mouth in case if there is any swelling of the tongue, or the tongue can get obstruct the airway. So they have a short, narrow trachea, especially the younger the child, the shorter, the more narrow the trachea is, and therefore it makes them very susceptible to a foreign body obstruction. Also, until late school age, cardiac output is a rate dependent, not a stroke dependent. And that is very significant because unlike adults, when kids need to compensate their cardiac output, adults are able to compensate for their cardiac output, but by increasing their stroke volume and the heart rate. Unfortunately, pediatrics, they're unable to increase their stroke volume. They're only able to increase their heart rate. So therefore, tachycardia in a pediatric patient is a significant marker that the child is trying to compensate for a cardiac output.
Can I
Also,
ask a question?
absolutely.
Okay, so in that circumstance, is even a small increase outside of normal in terms of heart rate an
Yeah.
indicator of a problem?
Well, it's not always a problem, Mika,
Uh-huh.
and we'll talk a little bit
Sure.
more about it, but that should be taken seriously enough and should be interpreted in light of other clinical conditions, right? That could be just, a sinus tachycardia as a result of maybe fever or maybe pain or crying, but increased heart rate could indicate other underlying condition, especially shock, right?
Mhm.
So, and in pediatrics, we don't take increased heart rate in isolation. It has to be interpreted in light of clinical conditions, and also it has to be trending. We have to see how this heart rate behaves over time, right? Is over time, does it keep going up, right? But it is increased heart rate is always taken seriously in pediatrics because that is one of the signs that the child is compensating for cardiac output. Very good question. Um, so also abdomen offers poor protection for liver and spleen, and therefore making them susceptible to trauma. Another pediatric difference is that until 12 to 18 months of age, kidneys are not able to concentrate urine effectively and do not exert optimal control over the electrolyte secretion and absorption. So that impacts electrolytes imbalance. Until later school age, proportion of the body weight in water is larger with more water in extracellular space, and daily water exchange rate is much higher. Also, blood volume. Blood volume is a weight dependent, so it's 80 mils per kilo. So if you think about the 3-kilo infant, so the entire, blood volume will be about 240 mils approximately. That is, 1 unit of blood, right? The entire blood volume. So that gives you an appreciation that, sometimes even insignificant blood volume losses that in adult would be just, insignificant, in pediatric patient can be quite significant. All brain cells present at birth, myelinization, and further development of nerve fibers occur during the first year. Head proportionally larger, making the child susceptible to a head injury. Also, kids have higher metabolic rate, higher oxygen needs, and higher caloric needs. And that's also significant because when they do experience respiratory illness, even if their oxygen saturations are fine, The recommendation still to give them supplementary oxygen just because they have a higher oxygen demands to start with. Until puberty, percentage of cartilage in ribs is higher, making them more flexible and compliant. Until about 10 years of age, there is a faster respiratory rate, fewer and smaller alveoli, and less lung volume. Tidal volumes are proportional to the body weight. And up to 4 to 5 years of age, diaphragm is primarily breathing muscle. CO2 is not effective expired when the child is distressed, making the child susceptible to metabolic acidosis. And until puberty, bones are soft and more easily bent and fractures. Muscles lack tone, power, and coordination during infancy, and muscles are 25% of weight in infants versus 40% in adults. So those are significant anatomical and physiological differences that, allows us to think that kids are not just small adults. Their anatomy and physiology are unique. So therefore, the treatments have to be adjusted to their anatomy and physiology. Any questions so far, please? We will go over some of the concepts later on in the presentation as they are significant to some pediatric conditions. So what is a general approach? So what are the general overarching principles of assessing the pediatric patient? So one of the principles is examine painful area last, right? And why do we do that? So reason being is that kids are, especially younger ones, are extremely sensitive to handling, right? So once you start touching them, you will induce crying. And as a result, you will not be able to assess the heart rate properly, respiratory rate properly. So therefore, observe first and then listen to heart sound and lung sounds after. It's really important to understand developmental stages and impact on the child's response. Be honest with a child. If there is something that is going to hurt, so, explain it to them ahead of time. Never try to make things up because, you'll lose the credibility and it will actually induce more anxiety later on and makes them more reluctant and hesitant to participate in care in the future. So what is a major component of a pediatric physical assessment? So we always start our assessment with a pediatric assessment triangle, and then we move down to pediatric primary assessment, and then we move down to a secondary assessment. Due to the restraints of time, we will go over in this session over pediatric assessment triangle and primary assessment. If you'd like more detail, pediatric assessment, including secondary assessment, we do offer PAIRS course in-house, which is an 8-hour course where we do go over full pediatric assessment as well as a pulse course. I just, focused on those two due to constraints in time. Anyone is familiar with the concept of a pediatric assessment triangle, or in other words, it calls initial impression, depending on what literature you're reading. Anyone is familiar with that? Anyone sort of, I'm sure all of you are utilizing on a daily basis.
Familiar with it, but great to have a refresher and
absolutely
drill down a bit.
yeah absolutely yeah. So depending what literature you're looking at, in some literature it calls pediatric assessment triangle, in some literature it calls initial impression, but basically it stands for the same concept, and it's based on at a glance assessing 3 major elements: appearance, circulation to the skin, or in other words, color, and work of breathing. So we used to call it in the past across the room assessment. So the intent is to glance at the patient and basically to categorize this patient or to distinguish looks good or looks bad. So what do we assess under appearance? Is there any abnormal tone, posture, any decreased interactiveness with the outside environment, any abnormal look or gaze, any abnormal speech or cry, any increased or decreased work of breathing, any abnormal auditory sounds that you can appreciate, any abnormal position that will suggest the child is struggling with breathing, and any signs of increased work of breathing, such as retractions, flaring. Circulation, is there any pallor, any mottling, or any cyanosis? Any questions so far?
I do.
Yes, Mika, please.
Thank you.
Yeah.
Going back to the your initial assessment, the physical appearance.
Yeah.
So any tricks to, like, babies and especially like toddlers, when they're well, they're tired, they're like cranky, or
Yeah.
maybe they just were up all night because they, were barfing.
Yeah.
How can you kind of quickly tell the difference between a dangerously lethargic child versus just
Yeah.
didn't get any sleep last night child, or a kid who has that fever and is like super tired from that?
Sometimes it is not easy. So try to stimulate the child and see how arousable the child. The child that is tired should be still pretty arousable, right? The child that is lethargic will be less arousable. But, sometimes you're right, it is not easy to distinguish. Yeah, yeah. Mm-hmm. But basically, even if the child looks tired, the child is not awake and alert. Even if it's not, if the child is not lethargic but tired, it is still concerning. Yeah, you cannot categorize it as awake and alert.
Yeah, okay.
Yeah, at the same time, I find that it's more tricky to distinguish, especially if you have infant who is crying. Is this just a normal cry, infants cry, or it's the cry that it's that level of inconsolable crying when parents are telling you, I've tried everything, normal consoling techniques that usually work and nothing works so far. So that is on the other spectrum of abnormal appearance, because it's the same as lethargy. It actually does indicate altered end organ perfusion, and you have to be as concerned as lethargic child.
Yeah, okay.
Which is also very tricky, because when kids cry, you think, okay, that's what they do. But it's that level of inconsolability that should be concerning. Yeah, yeah, yeah. Thank you for asking this question. Okay, so pediatric assessment triangle focuses on 3 independent aspects of physical assessment and reflect severity of illness and urgency of intervention. So in other words, is how sick and how quick, right? So it's an extremely useful concept that can be used along all pediatric sort of continuum of care. If they're in emergency room, in a waiting room, right? And the nurses knows that, the wait time is an hour until the patients will come to the front desk. So usually what nurses do, they come out of their desk and basically scan who is there in the waiting room. And just by utilizing pediatric assessment triangle, you're able to distinguish looks good or looks bad. And believe me, I'm sure you're using it as a clinicians on an everyday basis. If you come into the room, you unconsciously glance this patient and you're able in your mind to distinguish looks good or looks bad. Okay, so How do we sort of pick up respiratory distress? Just by looking at the child without doing any primary assessment, without doing any vital signs. So if the child is awake and alert, or could be slightly lethargic, but has increased work of breathing, that indicates that the child has respiratory distress. When the child already has abnormal appearance, so that which suggests that there is an altered end organ perfusion and the child is hypoxic, then what you will see is increased, but more likely decreased work of breathing. So the child has progressed from a respiratory distress to a respiratory failure. And many of you, just going back to the last slide, many of you perhaps know, unlike adults, children do not go to a cardiac arrest due to primary cardiac condition. Usually with a pediatric population, it is a respiratory distress that progresses to respiratory failure. Respiratory failure progresses to respiratory arrest, and respiratory arrest progresses to a cardiac arrest. So what about the next element of pediatric assessment triangle, which is a circulation to the skin? So whenever you have a poor circulation to the skin, which we at a glance assess by color, we have to think that this child could be in shock. So the colors that is acceptable to a pediatric population in terms of good color is pink color, right? So any paler, any cyanosis, any mottling is abnormal color. Sometimes it can be challenging. How do we assess color in the children of color? Anyone would know where would we assess color in different sort of diverse pediatric population? Where would be the best places to assess color? Anyone knows, guys?
Lips.
Sorry?
We're saying lips over here.
Yeah, lips, absolutely. Lips, mucous membranes, right? And also the palm of the hands. Yeah. What about appearance? So if the child has abnormal appearance, normal work of breathing, that will suggest brain dysfunction. So going a little bit more detailed about assessing appearance during pediatric assessment triangle. So what are we looking at? So we're looking at the tone. Is there any decreased or floppy tone? Is there any decreased interactiveness with an outside environment? We talked a little bit about the consolability, right? So whenever the child is inconsolable, that should be concerning enough. Abnormal look or gaze. So again, unless it is teenagers that sometimes, they try to distance themselves from the environment, the child should be engaged with a caregiver, healthcare provider by looking at them. So if they have such that distant, abnormal look or gaze, that should be also concerning. What about speech or crying? Crying generally is a good, especially if, the child is, awake and alert. However, is that, high-pitched cry, squealing high-pitched cry, that should be concerning to you as well.
In that case, with infants in particular, when the pediatric patient isn't verbal yet and not speaking, I guess we must rely on parents a lot, or the caregiver.
Absolutely.
To sort of like discern, or that's not their normal cry.
Absolutely. That's a very good point, Mika. In pediatrics, we heavily rely on the caregiver. And there are a lot of pediatric populations that have an altered baseline to start with, right? So you need to establish, kids developmentally delayed kids with other conditions, their baseline is altered to start with. So you need to find this information out from the caregiver. Yeah. And going back to one of our slides about color, some kids, as perhaps some of you've noticed, are just naturally pale or very fair. And, you know, you're questioning, is this normal or is this abnormal? So please ask the parents, is this how, you know, the child normally looks? Yeah. And generally speaking, in pediatrics, we heavily rely on parents. And, you know, we sort of provide care on the notion that the parent, caregiver knows their child best.
Mhm.
And sometimes, you know, parent, caregiver are concerned, but they can't articulate in what they are concerned, but they're just, you know, saying something is wrong. And that should be taken seriously enough because, again, they know their child best. Any other questions so far?
Nothing from this group, nothing in the chat.
Yeah, okay, perfect, thank you. So let's practice a couple of cases where we will utilize pediatric assessment triangle. So appearance, color, and work of breathing, and basically to distinguish, you know, looks good or requires, or looks bad or requires, you know, other prompt assessment. I'll put some cases up.
Okay.
So what do you guys think?
Huh.
So just based on
Yeah.
3 elements, right?
Yeah. So I'm going to read it out because our
Okay,
screen-
yeah, they
so
can
it says,
see. Yeah, I can read it out.
oh, sure. Thanks, Tanya.
Yeah, yeah. So pink 4-year-old playing with blocks. She's breathing easily and has a 2-day history of vomiting and diarrhea. Her mother describes her behavior as lethargic.
So over here, we're thinking looks good.
Okay, so looks and
Only
You're
'cause
right,
she's
you're
pink and playing
right.
with blocks.
But yeah, but just based on those, you know, 3 elements. So let's say, you know, you have 10 patients in Emerge to see. Is she going to be, you know, one of your first patients that you will scoop and take to recess for further assessment?
No, for sure not.
Yeah. So based on pediatric assessment triangle, so her color is pink. She's breathing easily. She is playing, right? So, you know, it doesn't indicate that she's lethargic. However, you know, again, going back to how do we, you know, address the parent and, you know, like relying on parent as a best resort. You know, I would ask mom, why does she, you know, thinks that the child is lethargic, right? What's her baseline? You know what I mean? And again, try in your findings, try not to, you know, dismiss the mother and say, no, she's fine. Just be objective and explain based on your findings what you see and reassure her that you will continue to monitor.
Yeah, her baseline might be a kid who doesn't sit still or play with blocks.
That's exactly it.
I knew something was wrong when they sat quietly and played.
Yeah. Yeah. Okay. A model 2 months old, breathing easily with a 12-hour history of fever.
Yeah.
Model, so
I don't like the model sound.
yeah.
Model.
Yeah, model is very, yeah. So we don't have enough information about level of consciousness. So we have 2 elements. We have modeled and breathing. Model is extremely concerning. Model color indicates a systemic involvement in vasoconstriction or vasodilation. Everyone has everyone has an idea what modeling looks like.
Yep.
Yeah.
Yeah.
Yeah. So basically, it indicates an alteration in a systemic perfusion. So, and whenever we see an infant modeled, we're really, really concerning. Sepsis, meningitis is very high on our differential, especially for an infant that is less than 3 months of age. Okay. So model is extremely, extremely concerning color. Again, sometimes we see infants when they get undressed, they can become a little bit, their perfusion changes as a result of the vasoconstriction because they're cold. So ask again the parent, right? So does your child normally looks like that when he or she is undressed, right? But usually when they're truly mottled, it's much more pronounced than just being cold. It's really like this patchy discoloration. Okay, 6-year-old, known as asthmatic, who presents in a tripod position, pale, with marked substernal indrawing.
Looks bad. Looks bad. That's bad news.
Looks bad.
Yep.
You guys know. Yeah. So yeah, tripod position, pale, marked substernal. Yeah. We don't have information about level of consciousness, but just the fact that he's pale, increased work of breathing. So definitely we need to scoop this child up and do further assessment and intervention. Pale, quiet 12-year-old with abdominal pain, responding well to all commands and breathing easily.
Yeah, let's say more of the good side, but we need more information.
Yeah, pale. Yeah, we need more. Breathing easily. Yeah. So, yeah. Okay, so out of all those 4 cases, which will be the first one that you'd like to scoop and do prompt assessment and interventions? Number 2, absolutely.
Number
Yeah.
2 or number 3?
Number 2.
Oh, number 2.
I thought it was 3 as
okay.
well.
Yeah, yeah. Number 2.
So number 2 before the one in tripod position? Oh.
Again, we need more information.
True.
But,
yeah.
you know,
Okay.
2 of them are quite, you know, sick. Yeah. Let's put it this way.
I'll send the 2 of them to recess, but maybe look at the baby first.
Okay, sounds good. Sounds good. So again, you could see how, you know, how this pediatric assessment triangle can basically, you know, categorize the patient very fast just by, you know, without doing any vital signs, looks good or looks bad.
Anya, I have a question.
Yes.
Sorry to interrupt. So if we go back to those scenarios of that, number 2 is a 6-year-old, you will take number 3 first. Is that correct? Same presentation, but older.
Sorry, say it again, please.
If number 2 is in the same presentation, but an older child, like let's say a 6-year-old, would you take number 3 first in that case?
Oh.
Number.
So if the baby wasn't a baby.
Yes, I know what you mean.
Yeah.
I know what you mean.
Huh.
Like I would say both of them are quite sick, you know, and both of them need to go to recess. Yeah, yeah, yeah.
Because of the circulatory.
The first one, you're concerned about shock that can decompensate very rapidly. And the second one, right? And the third one is, you know, could be very sick, asthmatic. So both of them could be, we definitely need more information. It doesn't provide enough, but both of them are quite urgent.
Yeah.
Thank you.
But so a follow-up to Rafiq's excellent question, would you suggest that the younger the child, so when you're an infant and when you're even a younger infant, that it
absolutely very high risk
scale of risk?
Absolutely, Mika. And the reason being that kids under 3 months of age, their blood-brain barrier allows the bacteria to penetrate through, and therefore we're really, really worried about meningitis. So if you have a modeled 2 months old, this is really concerning sign, and we want to rule out meningitis. So that explains why kids under 3 months of age have a full septic workup. Whenever they're febrile, we are doing a full septic workup, including lumbar puncture, to rule out meningitis. Absolutely.
Right.
Yeah. Okay, so just to summarize again, pediatric assessment triangle is based on appearance, work of breathing, and circulation. Appearance stands for picking up abnormal tone, decreased interactiveness with the environment, abnormal look, gaze, abnormal speech, cry, and circulation basically reflects in color. You want to pick up paler modeling cyanosis, and work of breathing stands for increased or decreased respiration, abnormal sounds, abnormal positioning, and retractions. So let's talk a little bit about any questions so far about pediatric assessment triangle.
Anyone from our virtual community? Jill, Larry, Charlie, Martha, any questions from you guys? Dimitri? Just type in the chat or jump in anytime. I think we're good.
Okay, great. So pediatric vital signs. So pediatric vital signs, as you know, normal according to age. Accurate weight is the key, as we mentioned before, in whatever we are doing to pediatrics, and the heart rate and respiratory rate are inversely related to the child age. So in other words, the younger the child, the higher heart rate and respiratory rate, and blood pressure is normally lower than adult. But what's important to know about pediatric vital signs, it is just a number, right? And if you look at the different textbooks, there is no absolute consensus of pediatric vital signs, right? So there is a variation. And the reason being is that every child, is different. But what's important to know is that pediatric vital signs, they need to be interpreted in light of clinical conditions. So pediatric vital signs, normal pediatric vital signs is a relative term. Children of various ages have different metabolic needs and therefore have different normal values, and vital signs are most beneficial and clinically relevant with their use for trending changes in patient status over time. And some institutions, in fact, they actually have a software where they're able to trend pediatric vital signs over time. But just to give you sort of appreciation of what are the parameters of pediatric vital signs and what is the best route of measurements of pediatric vital signs. So first of all, there is no tympanic temperature for pediatric patients. It's been proven that it's grossly inaccurate. Just it has to do with the structure of a pediatric ear canal. It will not give you accurate temperature. And kids from birth to about 5 years of age, approximately 3 to 5 years of age, the first choice is to do a rectal temperature. That is a core temperature. Kids that are greater than 5 years of age, the first choice is to do oral temperature. Axilla is not a core temperature in pediatrics. Axilla is just a screening temperature in pediatrics. So whenever axilla is outside of the normal range, outside of 36.1 to 37.1, nurses should be doing a core temperature. So the normal temperature for pediatrics is 36.5 to 37.5, taken by a core route, so rectally or orally. Fever is considered 38 and above. And we are really particular in pediatrics about the temperature. So we take temperature quite seriously, especially in infant. So if infant's temperature is less than 36.5, we actually do take active warming measures to increase the temperature up. So we'll try to put extra blankets. If the child does not respond, we'll put the baby in an isolate. If the child still does not respond, we'll let physician know, because when child has temperature instability, that could be an underlying sign of something pathological going on. So, and again, as you know, sepsis is very high on our differential. So, you know, we think, is this child septic, especially infants? We are really, really concerned of infants' temperature instability. Any questions so far? All right. So
yeah, Tanya, we do have a question. What age is your temperature range that you stated?
So normal temperature range 36.5 to 37.5.
For infants or
across all peds population.
Okay.
Yeah. Yeah.
Like up to 18?
Yeah.
Okay.
Yeah.
Okay.
Yeah. So again, you know, we're like, you won't see, you know, temperature being taken by core method every single time, especially when the child is inpatient. But when they do come to emergency room, when you really try to establish their accurate temperature, it has to be by core method. And then on G7, if usually when we get axilla temperatures that is outside of the normal range, we have to do a core temperature. So, and there are very little contraindication to do a rectal temperature. Usually, you know, if it's in perforated rectum or oncology patients, which is not our population, and for oral, whenever the child has respiratory distress, of course, you will not be doing oral. But other than that, there are very little of contraindication to go for those two methods. Heart rate. So as you could see, there are so many numbers for a heart rate, and you know, you're not expected to memorize. I do have actually code blue cards with pediatric vital signs, so feel free to get it from me as a reference, but it just gives you an appreciation. The younger the child, the higher heart rate, and then when they're approaching adolescent age, their heart rate becomes closer to an adult. And again, everything has to be interpreted in light of clinical conditions, and you need to know their baseline. But whenever you have abnormal heart rate, try to find an explanation. Why is the heart rate abnormal? Is the child dehydrated? Is the child in pain? The child has fever. So try to find an explanation why this heart rate goes up. So what about the respiratory rate? Again, the younger the child, the higher the respiratory rate. So for infants respiratory rate 30 to 60, and then as they're approaching adolescence, it's 12 to 16. Blood pressure. So there are many values for blood pressure, but what's really important to remember is the formula on the bottom, because pediatrics, say, generally speaking, they do not have hypertension. Usually when they decompensate and their compensatory mechanisms are failing, they're becoming hypotensive, which is an ominous sign of impending cardiac arrest. So it's important to know the formula that is sort of a lowest threshold of systolic blood pressure. So for kids that are greater than 1 year of age, the formula is 70 plus, in brackets, age multiplied by 2. So for example, if you have a 4-year-old, then their minimum systolic blood pressure is 74. Okay, so that is not a great blood pressure. It is a 5th percentile of acceptable systolic BP, but that is sort of a bare minimum that you'll accept. So if it's less than that, it will be considered a hypotension. Kids that are greater than 10 years of age, minimum systolic BP will be 90, and up to 1 year of age is 70. So that is a really, really important formula to know when you're questioning pediatric hypotension. And just a couple of clinical pearls. Sometimes we do measure BP by automatic BP machine. When the child is hypotensive, unfortunately, automatic BP machine may not give you the reading. So the gold standard is to do a manual BP and just to listen over pulse, to do a manual systolic BP. And we've had a couple of circumstances when child was in a severe hypotensive or decompensated state of shock, and automatic BP would not give us a reading until we did it manually. So lesson learned. Any questions so far? Okay, so after we did a pediatric assessment triangle, we moved down to do a primary survey or primary assessment, which consists of airway, breathing, circulation, disability, and exposure, or A, B, C, D, E. So this is a systematic approach that actually prompts you to do it in a systematic way so that you're not potentially going to miss any conditions, and you're not going to, jump into conclusion on a condition prematurely. So what do we assess under pediatric airway? Under pediatric airway, you want to assess vocalization. Do you want to assess any tongue obstruction, especially in young infants, any loose teeth or a foreign body? Is there any bleeding, any vomitus, any secretions that could be obstructing the airway? Is there any edema of lips, tissue, mouth? What is the preferred posture of the child? Are there any drooling, dysphagia, any stridor, any snoring, any gurgling that can suggest issues in the upper airway? And again, as you're doing your assessment, throughout your assessment, you're utilizing evaluate, identify, intervene cycles. So what that means, if you're doing your assessment of the airway and you discover some abnormalities, you're not going to move to breathing until you try to fix it, right? If there are lots of secretions, you're going to try to suction the secretions before you're moving to the breathing assessment. So again, more detail, sort of dive in on differences in the pediatric airway system. So kids, as you know, they have a small mandible, which makes it challenging to intubate. They have a large tongue, and their epiglottis is long and stiff, which again makes it more challenging to intubate. And the fact that they have a large tongue explains why kids up to approximately 6 months of age primarily breathing through their nose. So which in itself has an implication to some pediatric conditions. So, you know, if they have a bronchiolitis and if their nose is full of secretions, right? So they'll have difficulties breathing. So we need to ensure that, you know, they're regularly suctioned. So also kids have large occiput and highly compliant trachea. So on a slide, you see the recommendations. How do we position the child in order to maximize the airway opening? So as you know, in order to maximize the airway opening, infant we will position in a sniffing position. Older child will put like a blanket under the occiput versus infant will put the blanket under the shoulders. Oh, but the key is you basically, in order to promote optimal airway opening, you want to draw imaginary line so that the external ear canal is in sort of, there is a straight line over external ear canal and the anterior shoulder. Okay, so other very, very significant airway difference is the shape of the airway. So as you could see, you know, in adults, the airway is more straight versus pediatric airway is more funneled or cone shaped. And the narrowest area is around vocal cords and cricoid. So that in itself has a very, very significant implications in case if there is any inflammatory process around the narrowest portion of the airway, right? So if there is any swelling, then, you know, it actually predisposes to significant airway obstruction. So the next slide, it just gives you a bit more of appreciation what's happening in case if there is edema around the narrowest portion of the airway. As you could see in the infant, if there is an edema, then so the area decreases in 75% versus if there is edema in the adult population, it decreases only 44%. Any questions so far? Okay, moving on. So how do we perform breathing assessment? Assess level of consciousness, spontaneous respirations, rate and depth of the respiration, symmetric rise and fall of the chest, presence of quality of bilateral breath sounds, is there any increased work of breathing, and of course, oxygen saturation, and if we are using and tidal CO2. A couple of words about oxygen saturation. Oxygen saturation by no means is indicative of overall breathing status, especially in the early stages of a respiratory distress. Quite often during the respiratory distress stage, oxygen saturations are totally normal because the child is in a compensatory mechanism. So therefore, we can't rely just on oxygen saturation alone as an indicator of how the child is doing. Okay, so let's watch the video. Please let me know if you cannot see it. I hope everything will work fine. Oops, sorry. Let me just.
Tanya, we just can't hear her talking.
You can hear?
No, not her talking.
Oh, interesting. Okay. What about now?
Not yet.
Not yet, huh? Okay.
We can
Okay.
read the subtitles.
Yeah, I tested it before.
Yeah.
Okay, let me try it again. I'll try it again. I'm sorry.
It's okay.
Can you hear?
No.
No.
I think it might be like a setting on Zoom to let the sound from your computer from the video goes through Zoom.
Sorry?
I think it might be a setting on Zoom to let the sound from the video instead of your sound
Okay.
into the video. I would assume so. I don't
Yeah.
know.
Okay.
So maybe on
Okay.
maybe a Zoom tool, maybe a Zoom button, like in yeah.
Let me stop share and I'll try again. Okay.
Okay,
Sorry
sure.
about that.
Like maybe where the mute button is, and then there's the
Yeah.
arrow, and you can select different
Uh-huh.
audio options.
Yeah, I'm off mute and okay. Let me stop.